The speaker in this episode is going to be Dr. Manish Jain. He is a consultant at KIMS Hospital, Hyderabad. He is an orthopedic and hand microsurgery specialist with expertise in trauma care, upper limb surgery, and reconstructive procedures. He has done his FNB in hand and microsurgery in 2021, DIP&B in orthopedics in 2019, MS Ortho from 2018. He has got about 17 publications and research articles, and he is a member of the Indian Society for Surgery of the Hand, IOA, KOA, and the Brachial Plexus Society. He is a founder of the Helping Hands charity for orthopedic patients. The moderator of this session is going to be Dr. Praveen Bhardwaj, who is a consultant of hand surgery at the Ganga Hospital, Coimbatore. He has done his MS Ortho from KMC, Mangalore from 2000 to 2003, DIP&B Ortho, FNB Hand and Microsurgery from Ganga Hospital 2009. He has acquired the European Diploma in Hand Surgery in 2011. His special interests are brachial plexus, wrist and spastic upper limb. He has more than 124 scientific publications in peer-reviewed journals. As far as academic achievements are concerned, he is the editor of the Journal of Hand Surgery Asia Pacific Volume, Academics Chair at the Indian Society for Surgery of the Hand, and Scientific Committee Chair of the Asia Pacific Hand Surgery Meeting 2025. Dr. Manish is going to talk on a systematic approach to the stiff hand. Over to Dr. Praveen Bhardwaj.
I think this is one of the talks what he gave in Ganga when during his fellowship, and it was so interesting and so systematic that I always refer to this whenever I am giving any talk on stiff hand. And when he was asking me what talk he should give, this was the first thing which came in my mind. I think it will be quite helpful for everyone to just have a nice systematic way of managing this hand stiffness. Over to you, Manish.
Yes, sir. So I was telling at the outset, I would like to thank Dr. G. Karthikeyan sir for giving me this opportunity. It's indeed an honor for me to be presenting in this HASTAM program in this first season. So when sir asked what topic you would like to give, I also told distal radius fractures. And then sir told that Samrat sir is already telling the same topic. Then I discussed with Dr. Praveen sir, and as Praveen sir told, so why don't you give this talk on stiff hand? So I went back to the same talk what I gave in Ganga, but there are a lot of modifications which I have done now. So hopefully it will be more helpful now for how to systematically approach this stiff hand. So shall I start, sir?
Yes, please.
Yes. So we all know that this is a disclaimer. I've used some artificial intelligence and YouTube videos in this presentation. We all know that hand and fingers are gift to the nature, gift what nature has given to human beings, which the other mammals and other animals down they don't have. The reason is, if you see this video, Zakir Hussain is so fastly beating his tabla with his fingers, or this guy playing the piano, climbing the mountain with fingers. Or the kids drawing an art.
We were burning on the edge of something beautiful.
Fair amount with a handgun.
Or if a military guy is
sink it in
firing
there a
a
little
gun.
farther, close.
Or typing so fast with the fingers. Fingers can do magic and achieve things we have never imagined till date. But what if these fingers are like these? In the first video, the finger is not bending fully. And in the second, it is not extending. The stiff finger is a morbidity and disability to the patient. And still, we do not discuss this often. Why? So after thinking a while, I thought these are the reasons why we don't discuss stiff hand. There has been limited teaching in our postgraduate, sparse literature on this, very limited understanding of how this usually happens, poor results of treating surgeons, no standard protocol for treatment. And that is the reason why we don't often discuss this. So the aim of my talk is to how to systematically approach to a stiff hand. Whenever you see a patient with stiff hand, like I showed two videos where one patient was not extending and one patient was not flexing his fingers, you have to think of these structures which could be involved. The skin, the extensor tendons, the flexor tendons, collaterals, volar plate and capsule. Why are these standard structures? Because all three joints, the MCP, PIP and DIP joints have similar structures in their joints. And my talk is mostly confined to MCP and PIP joint stiffness. We all know the basic anatomy of the PIP joint. We have a proximal phalanx head with different shaped condyles in different fingers. The middle phalanx, it's a hinge joint, intercondylar notch, and there's a pit for collateral ligaments and accessory collateral ligaments. This is the volar plate with the chakrine ligaments. And this is the capsule, the collaterals, the volar plate, the flexors and extensor tendons as a whole. Because of the asymmetry of the condyles, we all know that whenever the fingers flex, they all point towards the scaphoid tubercle. That is because the asymmetry of the proximal phalanx condyle in the PIP joint. The MCP joint also has similar structures. If you see the basic difference of these two joints, the collateral ligaments in the MCP joint are tight in flexion, whereas in PIP joint they are tight in extension. There is more loose connective tissue anteriorly in MCP joint. There is a cam effect. There is a less connective tissue in the PIP joint. MCP joint has increased hyperextension, whereas PIP joint does not. MCP joint has multi-axial movements like flexion, extension, abduction, adduction, circumduction, whereas PIP joint has only flexion and extension. Then what causes the stiff finger? Most of the times it is post-traumatic, post-surgical, sometimes arthritis like rheumatoid arthritis or osteoarthritis, where patient can have pain and due to which they could not move. If you see, they can be divided into most common, less common and rare causes. We all know most common are trauma and hand injuries and post-surgery. Rarely you get diabetes, Dupuytren's, rheumatoid, gout. Very rarely you get congenital stiff fingers like in symphalangism or multiplex congenita arthrogryposis. Because of any of these reasons, the structures which are getting affected and causing stiff finger, this stiff finger can be anatomically divided into two things. Either there is an intrinsic cause or there is an extrinsic cause. Intrinsic cause is usually in the capsule or the joint. That means there is a capsular tightness or there is a synovial disease or there is a joint cartilage destruction. Extrinsic causes can be too many. Right from the skin, it can be due to injury or the burns, Dupuytren's contracture where fascia and the skin can be involved. Post-traumatic, there can be a flexor tendon, extensor tendon injuries or extra-articular fractures. And I would say very far extrinsic causes like CRPS can also lead to stiffness of the fingers. What happens, why the stiffness happens? Whenever there is an injury, there is edema, there is hemarthrosis, which slowly get fibrosis, fibroblast, and there is an increase in volume of this tissue fluid, which can also seep into the normal structures. If you see if any hand injury or a distal radius fracture or a forearm injury, you sometimes get edema of the hand without any fractures, visible fractures. There's an edema fluid which is all over the place because of the thin skin on the dorsal side. So this edema fluid, if it is long standing, if we don't elevate the limb properly, they can slowly seep into the interosseous muscles, lumbrical muscles and into the MCP joints, due to which you get this stiff fingers. Usually the fingers can land into a flexed position or an extended position. There can be scarring of the soft tissue. And because of that, there can be adhesions in injured as well as the uninjured zones, like how I explained. So whenever the patient comes to you, what is the thing you need to see is basically the more important point is the history, where you know what is the mechanism of injury, how severe was the injury, and how long it's been. It's an acute, chronic, long-standing, whether the patient has got any prior treatment, like there was a K-wire fixation or somebody put a plaster, and did he do any rehabilitation. So with this, we'll get an idea whether what is our next step. And once the history is taken, this is where we start examining the patient. So as I told in my previous slide, the important structures are all common for all the three joints. So we see all these structures. So we start from the skin. We ask the patient to do active range of movements of the fingers and we record it. Then we do a passive range of movement. And in long-standing cases, we should also look for some intrinsic tightness. If you come to the skin can be contracted either on the palmar side or the dorsal side. It can be a post-burn contracture, or it can be a skin graft which has got contracted and causing stiff finger. So most of the times, if only skin is involved, there will be a passive range of movements. And during the passive range of movement, you can see the skin tethering on the opposite side. Sometimes, if the cases like this where the post-burn contracture, very severe flexion contracture, you can't even do a passive range of movement. So that means there can be involvement of skin as well as the structures underneath. How to evaluate for the tendons? Once the skin evaluation is done, if you think the skin is normal, then we look for the tendon causes. If we are thinking of flexors, always if there is a flexor tightness, there will be extension will be difficult. And passive extension will be difficult with wrist extended and wrist neutral. And once you flex the wrist, there will be a good passive extension of the fingers if the cause is flexor tightness. This is similar to what we see in VIC, like a Volkmann's sign. Whenever you flex the wrist, your long flexors have become lengthened so that you get good extension of the fingers passively. What about extensors and lumbricals? If there is an extensor tightness, suppose, and the flexors are normal, patient will have difficulty in actively flexing the MCP as well as the PIP joint. And we also look for the extrinsic tightness of PIP joint by flexing the MCP joint and trying to flex the PIP joint passively, like in this video. If you see you try to flex the MCP joint and then you try to flex the PIP joint. See, it's very tight. That means it is long extensors are tight. And when you do the opposite, you extend, that is Bundle's intrinsic tightness test. When you extend the MCP joint and then flex the PIP, it will flex. So this patient had a metacarpal fracture of the fifth metacarpal and managed conservatively. Then she landed into stiffness. In these cases, the passive flexion may be or may not be possible, depending whether the joint is also involved. So always remember, when the passive movement is not possible, you first think whether the joint problem is also a reason. If there is a joint injury, obviously the joint will not move. Sometimes if there is overlap of joint and tendons and there is no passive movements, we cannot differentiate what is the exact cause. But when the passive movements are possible, it is sure that there is no joint problem. So how to see whether there is a joint capsular collateral issue? So there will be minimal or no passive movements, as I told. And of course, where there is a joint problem, there won't be active movements also. So in the skin, we see that mostly passive movement will be possible, and when you are doing a passive movement, the skin will be stretched. In flexor tendons, only when the wrist is flexed, then the finger extension will be possible. And in the extensor tendons, we look for the extrinsic tendon tightness as well as intrinsic tendon tightness. And in this, both, if the passive movement is also not possible, then we have to think of joint involvement. And for the joint involvement, there will be no active as well as passive movements possible. Whenever you see all these structures, always keep writing down on the paper or in the file, because this patient might not immediately turn up to you. He will go for multiple reviews. Again, he'll come to you after 7 days. You will have forgotten. Again, you'll have to examine. So when you write it down, it is easy for you when the patient comes for follow-up and also to plan for the treatment of the patient. The documentation is more important. So then you have seen all these structures individually, and then you see the attitude of the finger. It can be divided into two types, whether the stiff finger is in flexion, as you see in the right side, or the stiff finger is in extension, as you see on the left side of the picture. You can broadly divide. So the clinical judgment is restricted. Active only tendon injuries, if you want to see, always assess the range. I'm just revising what I have told. If the active movement is restricted but passive movements are normal, then pathology is usually on the side of restricted movement. That is, if the active extension is restricted, then pathology is on extensor tendon side. In a similar, if the passive movements are also restricted, then pathology is on the opposite side of the movement restricted, or it is a joint problem also, like I told. And once you have an idea that what it could be, always try to get a radiological diagnosis. X-ray is must to see how is the joint position. Sometimes if there are multiple or comminuted fractures, small unit, you might also require CT scan. So once you take X-rays, you can see multiple variation. You can see a volar dislocation, dorsal dislocation, or sometimes there is no dislocation, but there was a comminuted fracture which has healed with arthritic changes in the joint. The X-rays will tell you the status of the joint. So before we move to the treatment, how could we prevent this stiffness? We should always treat a finger as a part of hand and hand as a complete organ, because though there can be injury to the single finger, but all the fingers can go into stiffness. So when you know that single finger can be managed separately without getting involved the other fingers, try to mobilize the other fingers, just keeping the injured finger splinted. Early rehabilitation from a qualified hand therapist. I have written specifically this qualified hand therapist because we see many cases just beyond squeezing a ball, they don't do anything for hand rehabilitation as a general physiotherapist. It is always better such cases where you have stiffness and patient has come to you, you have to get in touch with the hand therapist and always individualize the treatment. Every patient has a different way of recovering. They have different pain tolerance. So you cannot give a same protocol for all the patients. So why do I say so? You can see by this example here, this patient had a distal radius fracture, and now after 8 months she has complete stiffness of the wrist in flexion. It is not extending even passively. And if you see, the MCP joints are also stiff. It is typical like a VIC kind of a picture. All the 4 fingers are landed in trouble. PAPs are supple. Even the pronation supination is restricted. So if I see the X-ray, this was the X-ray immediately post-op done elsewhere. If you see, the patient has been immobilized in a wrist flexion as well as ulnar deviation, and if you see the slab extension, it is extending beyond the MCP joint. And when I asked for how many days this plaster was put, she told it was put for almost 2 months. And after that, this position never recovered. She is still in this position despite physiotherapy. So why the reason why I told hand as a full organ is because you can land all the fingers in trouble because of distal radius fractures. And the way the slab was applied, you never put the slab beyond the MCP joint, and you start early mobilization. Despite fixing with a plate, this patient was immobilized for 8 weeks, and now this is the condition of this patient. So you always immobilize in the position of safe, which is 20 to 30 degrees of wrist extension, 70 degrees of MCP flexion, and IP in extension. And you can always give a customized splint to the patient if you have good passive movements for the joints. And if the patient lands into stiffness, sometimes you can manage this patient non-operatively. If you know that passive movement is coming, then you can manage them with serial casting or splinting, ROM exercises from physiotherapy, and start on relative motion flexion extension exercises, and have a track record of this in the file with the dates mentioned to to just see how much the patient is progressing. Hand goniometer will be useful in such cases. These are early active assisted therapy, how you ask patient to do rehabilitation for stiffness. So individual fingers, the hand therapist at my center. And for the wrist, so non-operative treatment do work. If the patient is improving, you have to have a check every week. Sometimes dynamic splints also help. This was the picture taken when I was doing my residency at Ganga. Anti-edema measures, Coban bandage are very useful. They definitely reduce the swelling and improve the range of movements. Operative treatment, when your conservative treatment fails, then we either do a percutaneous release. I have no experience with this, and open release. I usually do open release. Percutaneous release is for a patient just improves 20 to 40 degrees, usually done for osteoarthritic patients or patient who have undergone prolonged immobilization. This can help a bit, and then you add on with physiotherapy. But when you're planning for a surgery, you have these three components. You need to know what surgical approach is better, what tissues to target, and then what rehabilitation protocol to be put. So you should also see whether are you going to do in a single stage or a stage procedure. For that, clinical examination is important. If you feel both flexor side and extensor side are involved and it requires an extensive release, it is better to do stage procedure. And then after one part of the movement are improved, then you can start for the second stage. It is not by calendar, not because after 3 weeks we'll do second procedure, after 4 weeks we'll do. It is based on the patient's improvement. We decide on when to do the second stage procedure. Open methods, if you see on the flexor side, we release the skin. We do a flexor tenolysis. In this picture, you can see the entire flexor tendon had a fibrous tissue. If required, we will release the entire A2 pulley, check-in release, and then keep doing the passive movements. If you are able to achieve a full passive movement, then you can start him on early rehabilitation. So same things, we go from skin, flexor tendon, pulleys, then tendon tenolysis, then volar plate, and then if required, arthrolysis of the PIP joint and collateral ligaments. Sometimes we use extensor external fixators, like this patient which I showed initially had a kind of arthritic joint. It was 3 months old. Then we thought of distracting. So the joint was able to distract. And then patient went on to develop good ROM. Extensor release for extension contracture. If you see, we can release between the lateral bands and the central slip. We have to release the entire fibrous tissue, excise it, and then separate both the central and lateral slips. So this is one of the patient. He is a cricketer who had a cricket ball injury. His middle phalanx had a base fracture which was united. The joint is stiff. This is under anesthesia. Complete extensor tendon stiffness. MCPs are stiff. MCP is not flexing. PIP joint is not flexing. It is in both the fingers. In second middle finger only MCP is tight, but the PIP is okay. Ring and little fingers are normal. So we went on to expose both MCP and PIP joint of index finger, and after thorough tenolysis and MCP capsulotomy, he developed full ROM passively. It is very satisfying when you see that patient has full passive range of movement. But then this happiness stays for a very little, because once patient is out of anesthesia, the pain of arthrolysis and tenolysis is much more than what he initially had. And then the rehabilitation becomes much more difficult. So sometimes we keep calling them to OPD and give them local anesthesia and then keep moving them. So this is after finishing both the fingers, middle finger also MCP. So few points to remember when you're doing MCP capsulotomy. You can go through a split tendon approach, or you can go with a paratendinous approach. When you're going with a paratendinous approach, you need to suture back your lateral slips, and dorsal capsulectomy to be done after that. Usually the proximal phalanx pivots over the metacarpal, if you see under the C-arm. Because the volar plate pouch is not created, then we have to use an artery forceps mosquito to create that volar plate pouch, then it will glide nicely. So to summarize, if the finger is stiff in extension, these are the two scenarios. Restricted active flexion, that is why it is in extension, but the passive flexion is possible. That means there is flexor tendon adhesions or flexor tendon disruption. There is a finger is in extension, it is not flexing. So we have to either repair or reconstruct the flexor tendon if it is ruptured, or if it is adhered, you have to release the flexor tendon. If the restricted active and passive flexion is there, even passive flexion is not possible, then we have to think of the joint pathology. So we have to go into the joint, do a tarsal capsule release, contracture release, volar plate release, tendon adhesion. Always start on the dorsal side first, and then release the capsule, everything, and then you check whether you are getting passive flexion. If still passive flexion is not possible, you can do under Valent also, and active flexion is not possible, then you can go and do with flexor tendon release also. If the stiff finger is in flexion, then these are the scenarios. Of course, there is active extension is restricted, and even passive is extension is restricted, means there can be a joint problem. So we can do a staged procedure. The first stage we release the palmar plate, and then second stage, once the extension is, you can reconstruct or rebalance the extensor tendon, because sometimes extensor tendons will be lengthened. If there is a restricted further active flexion and restricted passive extension, same thing, flexor tendinolysis, palmar plate release, lateral ligament release, and skin contracture release as well. A note on intrinsic stiffness. Intrinsic stiffness is very long standing finger stiffness will land into intrinsic stiffness. I don't have any experience with any case of intrinsic stiffness yet. This is the picture from the greens, which tells that you release a tissue, a triangular tissue, where the interosseous lateral tendon merge with the lateral slip. Just before the merging of the interosseous with the lateral slip of the extensor tendon, you cut that. So that is a pictorial representation. So my take home message is prevention is always better than cure. Complete knowledge of anatomy is very important here. Clinical test to diagnose the problematic tissues and write them down. And surgical management and early rehabilitation by hand therapist if the patients are not getting well with non-operative treatment. Thank you.
Manish?
Yes, we are able to hear you, Praveen.
You're able to hear me?
Yes, we are able to hear you.
Yes, sir. I was just checking whether there are any questions in the chat box. Get good relief with physio and then immediately swelling and pain along the stiffness. So when do you...
Okay. Sir, sorry, sir. I just logged out. I just joined in, sir.
Okay. Nish, there is one interesting question which has come, and I think that question itself kind of important summary of how difficult stiff hand is to manage. So you do physio, they look like having a good relief. Then swelling comes, and then stiffness persists. So in this cycle of physio, stiffness, when do you think that we should go for surgical intervention?
Most of the times in these cases, first we have to rule out CRPS, sir. So sometimes when you have CRPS, we have to look for other features of CRPS where patient has swelling, loss of sweating, shiny fingers, diffuse pain. And if you see both the hands, if you compare, you will see a very nice difference where, and female patient especially, if we are having any doubt of CRPS, I would never recommend a surgical release. And or the more reason to give more physiotherapy, occupational therapy, mirror imaging therapies will help. If we don't see the features of CRPS, but still the patient is trying to improve his movements, then again is getting swelling, and that means I think your anti-edema measures are a little to be hyped. We should tell the patient to go a little gentle and see if still they are not improving, then we advise them for a surgical release. Because unless if they're getting a good movements when they're doing physio, I would have very high threshold to go for a surgical release.
I think I always like your this talk because it is a nice systematic way of assessing the stiff hand, and true delight to the hand surgeon because it is a real applied anatomy. And I saw you have mentioned that you have not seen any case of the stiff intrinsic tightness yet. But the day you see a case of intrinsic tightness and release, you get more belief in the anatomy and the love for hand surgery because it is such a magical thing that if you are able to diagnose it, the day you release the intrinsic muscle, the next day patient is bending the fingers so nicely that it will really increase your interest in managing stiff hands. Yeah.
I'll wait for that day.
So just to summarize and re-emphasize what you have told, I think your last slide correctly tells that prevention is the most important thing. But when we are dealing with the stiff hand, there are three basic components like patient-related things, injury, and the surgeon. The injury, we are not having any control. Surgeon, yes, when we are operating, we need to be very careful about the handling of the tissues, not think that bone is the only thing what we need to fix properly. On the way to the bone, we need to handle of the soft tissues well. And more importantly, during the post-operative period, so one basic dictum is just to immobilize the part which you intend to immobilize and move everything else. So if we are able to follow this small advice to ourselves and keep it in mind all the time, then most of the stiff hand things will not happen. I think the most complex one is the patient factor. And not that patients don't want to become okay. Everybody wants to become okay. But there are some links or some patients who are naturally respond very badly to any trauma. They throw a lot of swelling, lot of edema, and their pain tolerance is less. Their compliance to the exercise is less. And we know that there are various level of the depressive nature of patients. There are some patients who will tell that I will do exercise, but they are just not able to do. So such a patient who has stiffness and you treat such patient, the same patient factors still are there. So even after surgery, that same factors are going to hunt you and may result in the bad outcome. So I think we need to be very, very selective when we are doing these patients and taking them for surgical intervention. And once you are really sure that the patient factor, especially that compliance part is sorted out, then only you go for surgical interventions. And the way we decide on what treatment you do when you're operating is a very nice thing. So I think just to emphasize what you already told. So first we need to see whether the passive movement is less or active movement is less. So if the passive movement is not there, then the problem is basically in the joint. It can be associated flexor extensor tendon problem also, but joint is a problem. But if passive movement is good and active movement is not there, then it is not a joint problem. It is basically the soft tissue problem. So one thing which you get in your mind, okay, when I am operating, I have to more concentrate on the joint, or when I am operating, I need to more concentrate on the flexor or extensor tendon. And when you are doing a complex stiff hand, always the end point is to check whether the flexor has started gliding correctly. Even if you do the extensor side release, we always should open on the flexor side and check whether the flexor is gliding, which is called as a traction flexor check. So if you release all the extensor side, passively you may get movement, but next day patient may not move. So we need to make sure that this flexor also has not got adhered over a period of time. So that is one thing which sometimes you would have, you may remember, we just forget and then we remember, oh God, we forgot to check that flexor side, we need to check. And when we open, we will see, oh, it was already stuck there. So that is one thing which always we should keep in mind. So though the volant is a nice thing, you can see that patient is moving in front, but sometimes it can be very challenging because you need to open on the extensor side, you need to open on the flexor side, and there may be more edema with multiple injections. So till now we are quite okay with doing the traction flexor check, which kind of gives you a hint whether the flexor tendon gliding is quite comfortable. Then you very nicely mentioned about the physiotherapy. I think one thing which, if we are able to convey to our physio friends, this ball exercise is a real sin for hand stiffness. So all patients, first thing they do is they come with that, I am you doing the ball exercise. But if we see, if there is a ball in the hand, the finger is not flexing at all. So it is a recipe for developing a stiff hand. So if we are able to convey to all our therapists that this ball exercise is the last stage of rehab where you want to increase the strength of the hand, first the range should come, then only the strengthening exercise also have to be started. And to our friends in the surgery side, I think one other thing which we need to be really putting aside is the closed capsulotomy of the MCP joint or the PIP joint, because closed capsulotomy, especially for the MCP joint, is not a nice thing. Because whenever you do a MCP capsulotomy open next time, you observe that passively, if you are forcibly flexing the MCP joint, they may appear that you are getting the flexion, but if you see the joint, it is only hinging. It is not gliding. The base is not gliding on the metacarpal head. So that is an unnatural movement which you are able to induce under anesthesia. And that movement patient cannot generate post-operatively. And it only causes more swelling and more problems. So MCP closed capsulotomy again is not a very nice thing to do. And last, I think the most important, prevention is the best. Because it is the stiff hand is a kind of vicious cycle. First one thing will get involved, then the next thing, and that way all like a chakravirya, all flexor tendon extensor, all things may get involved. So when we are seeing the patient from the very first day itself, we should suspect that every patient we see is going to get into some stiffness. That possibility is there. So when you are doing a surgery, just be careful about the soft tissue handling. When we are putting wire, we should make sure that our wire is not close to the tendons so that it does not disturb the gliding. It should not be close to the joints so that the movement is not restricted. Like suppose putting the K wire for metacarpal fracture, we should never go from the metacarpal head side because that is going to block the finger flexion. And in the post-operative period, most important, elevation. We must prevent edema because edema once happens, it is like a tissue glue, which is a recipe for stiffness again. So if we are able to prevent swelling in the early post-operative phase, that itself is going to prevent our long-term stiffness in these patients. And yes, when we have to deal them surgically, we need to be really aggressive. Go for the tendon, go for the extensor tendon and go on to the flexor side and select a patient who is really going to fight along with you with this stiffness. Because 3 months they have to really be invested into this procedure if you are doing a surgery for a stiff hand. Thank you for bringing that
Yes,
topic.
I had a patient who had a stiff finger after flexor tendon zone 7 injury repaired, and then landed into stiffness, went into CRPS. So he has bought all the appliances, instruments, splints possible in Amazon, Flipkart. So he has one small handbag in his whenever he comes to physio, and he has tried so much for 3 to 4 months to just get at least 20 to 30% of the movement still. And he's still researching. He has got every appliances of finger splints, everything, which even therapist won't have. So as you said, you should have a patient like you who is there in this fighting for himself and for us as well. But we
So,
rarely get them.
but sir has put one aggressive physio is the main cause for stiffness. That is
Totally
also
true, sir. Totally true.
what should be the approach for fixed flexion deformity secondary to neglected central slip extensor slip injury?
So usually, if it is a fixed flexion deformity, then definitely the joint is involved. So before we reconstruct the central slip, we need to get a passive and full movement. So it is better to go from the flexor side, open, do a tenolysis, do a volar capsulotomy, and check-in release, get a full extension, full flexion passively, and then you can reconstruct. And then that is how I feel. Either it can be done staged, but it is better once you get on table full movements. It is better to do it in the same stage. Like any tendon transfer principle. GK sir has asked one question where when there is a burn on the dorsum of the hand, we want to keep the MCP joint flexed, but will it not affect the healing of the wound? So what becomes more important here, the wound healing, well, or the joint mobility? I think, sir, every time it is a wound healing, which is a priority first. If we think that wound is getting gaped, it might require a augmentation by a flap or a full thickness, but over the joint, it is always better to have a flap if the skin is not getting closed. And once that is healed, we can always treat stiffness as per our principles, what we have spoken now.
Okay. There is a interesting question from Dr. Vignesh. Is Walent really helpful in managing these stiff hands?
You already mentioned, I think, sir, no, just a couple of minutes ago.
Yeah. So,
Yes, sir.
yeah, we discussed about that. Yeah, it is a kind of, we need to balance it. Think if it is only the flexor, if with good this flow chart what you had put, we are able to point out that it is mainly the flexor adhesion which is causing the problem, then Valent is very good.
Or
But
maybe
if,
single finger and only PIP joint level, if it is there also,
yeah,
we can still.
Yeah, because if you are going to do on the both sides, then it can become complex because of the lot of swelling which can accompany it. Is true.
Yeah, so today, thank you, Dr. Manish and Dr. Praveen. We had a very interesting talk on something that is very common. Everybody faces it, but it is sometimes challenging to correct these problems. And as Dr. Manish said so correctly, prevention is the best part of it. But what I tell my residents is, you advise physiotherapy, the patient will do even the best patient can do physiotherapy for a maximum of 3 hours a day. The remaining 21 hours, the nature is working against what he has done so far. So there, your splints also. So it is always a balance between immobilization and mobilization. Both have to be used at the correct proportion, at the correct time. Only then, as Manish said, we can get good results. And the discussion by Praveen also was very interesting because he noted down all the important points. I mean, this session can be a landmark session actually for stiff hand, how to go about managing stiff hand. So both the sessions we had today, the lower end radius fractures and all the surrounding problems that can occur and the stiff hand, both have been, I mean, it shows that the younger generation is sort of into what is, I mean, I can see the passion that is there with trying to get good results in hand surgery. And that is perhaps the most important thing, ultimately, isn't it?
Yes.
Yeah. So thank you, Dr. Samrat, Dr. Ravi Bharadwaj, Dr. Manish, and Dr. Praveen. We had a wonderful session today. We'll meet again after 2 weeks. Thank you very much.
Thank you, sir.
Thank you, sir.
Thank you,
Thank you,
sir.
sir. Thank you. Thank you. Thank you. Bye-bye.